Hello there and happy end of the day on Wednesday. Thank you for joining me live here. If we haven't met, my name is Julie Hirschberg. I'm a neurologic physical therapist. I run an integrated rehab center in the Los Angeles area. And one of my many passion areas is dystonia. And so we're just put out that we're doing a workshop for people with dystonia, and I started getting a bunch of questions. And in fact, I posted today a video of one of our favorite activities that actually our DPT student, Zach, this is his last week, congrats, Zach, filmed with Chelsea at our Torrance Clinic. And it's one of our favorite things that we have used for cervical dystonia. And I just got a lot of questions. So I thought, you know what, I'm going to do a video tonight and talk about some of the basics of dystonia. Some of the things that people have asked is just like, what is it? Is this dystonia or not? What about the different types of dystonia? So like, is this functional dystonia? Is it idiopathic dystonia? So what is it? What are the different types? What about treatment? So what do we know about treatment? And particularly, does treatment work for different types of dystonia? So we're going to hit on those like quickly. Otherwise we'd be here all night. You know, I could talk all night about dystonia, but I just want to get some of those pieces. I thought it would be helpful. So let's talk about dystonia. Dystonia is a movement disorder. In the umbrella of neurology, when you're a neurologist, you can actually subspecialize in different areas. One of those areas is movement disorders. It's one of my first loves in neurology, and particularly since I started Re+active about 12 years ago, I've done a lot with movement disorder neurologists. So dystonia fits in that category of movement disorders. It's an abnormal movement. And what it is involuntary, so not under voluntary control, muscle contractions. And they tend to cause repetitive or twisting movements. So that is the definition of dystonia. So sometimes when people ask me about their symptoms, it's like, is it tremor? Is it dystonia? Is it chorea? Is it a tic? Is it a seizure? All different things that we might see in movement disorders. The most common type of dystonia is cervical dystonia. It's what we most commonly see as well. But we also see all kinds of dystonia. So dystonia can happen in Parkinson's disease, either from the disease itself or from medication. We can see dystonia as part of Huntington's disease. We can see genetic dystonias. Some of the genetic dystonias and other dystonias actually respond to medication, dopaminergic medication like Sinemet. So the type of medication somebody with Parkinson's would take. Some of the more common types of dystonia that we see are focal dystonia. Focal means in one body part. And task-specific dystonia, meaning it occurs with a task. This is really common in athletes. Runner's dystonia, for example. Excuse me, I probably need a sip of water. So runner's dystonia is really, I shouldn't say it's really common. It's actually very rare in runners, but it's a common one that we see. Musician's dystonia, writer's cramp, which I've also seen with painting, for example. So those focal task-specific dystonias tend to occur in repetitive, in folks that do a repetitive task. So musician, typing, writing, painting, maybe if you're an artist. I just saw like a little question mark come up. This is cool. I didn't know this could come up. So thank you, Simone Catherine. Is splinting an option for dystonia treatment? I'm going to chat about dystonia treatment here in just a minute. It is an option, but I have some caveats with that. So great question. Thank you for asking. So I wanted to, because particularly folks had asked about dystonia and functional dystonia, I wanted to bring back a post that I had shared before looking at the differences, this is based on the literature of idiopathic dystonia, which includes task-specific dystonias, cervical dystonia, genetic dystonia versus a functional dystonia. Now, there's clear distinctions here, but I will also tell you, I see a ton of overlap. We know functional symptoms are more prevalent in movement disorders in general. So it doesn't have to be either or. Often it's both. So idiopathic dystonia versus functional dystonia, the onset is different. So an insidious or slowly gradual versus a sudden onset. The precipitating event beforehand, there's usually not one that is seen in idiopathic dystonia, but some sort of physical trauma or injury is very common in functional dystonia. There's a course of the disease, so slow progression and rare remission where it just spontaneously remits, whereas a course in functional dystonia has a rapid progression and there may be full remissions that occur. And has variability to it. For example, I met a young girl today who was developing cervical dystonia that seemed to come on due to an automatic trigger, autonomic trigger. I said automatic, autonomic, with cold. And so that's not typical in idiopathic dystonia. My brother signed in. Thank you, Matt. That is so nice. He finds this interesting. It is really interesting. That's so fun. Hi, Matt. So the clinical exam. So this is really important. As a therapist, we're going to screen for the presence of these. In idiopathic dystonia, we see repeatable pattern of muscle contractions, whereas in functional dystonia, we see a variable pattern. Attention can change it. Cold can change it. So again, I was talking to a young girl today who's getting cervical dystonia. It seemed to be triggered by cold. And at one point it was to the right and the other point it was to the left. That is not what we see in idiopathic cervical dystonia, but in a functional dystonia. So that is one of the key differential diagnosis questions when it comes to dystonia. But there are so many other types. I love working with dystonia of every type, Parkinson's, Huntington's disease, genetic, these focal dystonias. Now I want to share our pie chart. And we'll start talking about treatment. I wrote down all y'all's questions and I want to make sure I got them. What is it? What about the different treatment types? Is treatment similar or different for different types of dystonia is what somebody asked. And there is a common approach, though there are some differences when it comes to things that may respond to medication, like when we're talking about Parkinson's, genetic dystonias, Huntington's disease, things like that. We definitely want to work with a medical provider from a medical management standpoint for those types of dystonia. But when it comes to neurorehabilitation, there is a common approach. And of course, if you know me, it involves a pie chart. And I'm so happy, actually. The young girl I met today, she loves key lime pie. This is very much a key lime pie chart. I love the green colors. And you'll see if you have heard about our framework before, this is our approach to neurorehabilitation, and it's our approach to understanding some of the mechanisms that may underlie the onset of dystonia, which is then why we want to go down to those pieces from a treatment standpoint. Top to bottom, on the right hand side, we have motor control, we have sensory, psychosocial pieces, lifestyle, autonomic, and physical limitations and we would address these all, and they're very person specific. So we need to assess these areas to determine what might be contributing to a person's trouble in dystonia, and then we treat that. For example, the young girl I met today, where there seemed to be an autonomic or maybe sensory trigger for her cervical dystonia, that piece of the pie, the sensory and autonomic piece, might be really big, and we would address those pieces. So another question came in, and these are great questions too. And you know what, Paige, thank you so much for asking. Going back to a diagnosis standpoint, they were asking, is dystonia prevalent in the pediatric population such as CP? Yes. So I left that out in our differential diagnosis, but that is so important. There is a subtype of CP that may have dystonia present along with other movement disorders, and we can see that. We can also see cervical dystonia. There is a overlap with spasmodic torticollis in kids as well, but when we see it develop later than at birth, we would call that cervical dystonia. We can see it in functional dystonia in kids. One of the more common that I've seen is in CRPS, complex regional pain syndrome, in kids and developing a fixed dystonia. So really great question. And we do see dystonia in kids. Really important to screen for it and to look at underlying issues. Do they have cerebral palsy? Do they have maybe an encephalitis or another brain condition that might be causing the dystonia? Because typically we're not seeing child onset Parkinson's disease, for example. There might be genetic dystonia, absolutely, in children, and maybe juvenile Huntington's disease as well to think about. Great question. Thanks for asking it. I love the differential diagnosis stuff. Okay, so the dystonia treatment can be applied to any type, any source of dystonia. It's very person specific. Great question. I love y'all's questions. Okay, so I'm going to answer this question as well. That's why I'm here. I'm here to answer your questions. What is cervical dystonia and the difference with functional dystonia? Great question. Cervical dystonia is dystonia in the cervical spine. And what you typically see in idiopathic cervical dystonia is some combination of a turning or tilting of the head. Sometimes it's backwards, retrocollis, sometimes it's forward, and even could be a dropped head. So it's an involuntary muscle contraction around the neck. You could have functional cervical dystonia. So like the young girl I saw today, she had functional cervical dystonia. It had variability. It had these sensory and autonomic triggers, but primarily the variability is what brings it into the realm of functional cervical dystonia versus an idiopathic cervical dystonia. You can certainly have components of both of those. So really great question. I'm going back up here because somebody else asked, with CRPS, is it common for dystonia to develop? It is not common, but it can occur. So again, I had mentioned this in the differential diagnosis, complex regional pain syndrome. A person with CRPS can develop dystonia in the hand or the foot. It doesn't always occur, but it can. And it's a functional dystonia, as CRPS is a functional neurologic disorder as well. So you can see, as we're chatting here, for things that I'm trying to give you the basics about, it's actually pretty complex, right? There's a lot of overlap and pieces that intersect here. Oh, great question. So we got some really like in the know folks here. Is this based on the Carrick approach, which is really well-known neurologic? I have a lot of colleagues that take training courses with the Carrick approach. Is chiropractic involved? So this is not based on the Carrick approach. This is based on the neuroscience and neurophysiology in the literature on cervical dystonia. Chiropractic could be involved. I've worked with chiropractors. I'm not a chiropractor. I'm not trained in the Carrick method either, but I will tell you, because I study and have taught neuroanatomy and physiology and teach neuropathology, a lot of those components that I see in the Carrick courses really come into play in understanding the neurophysiology of dystonia. Really helpful. Yes. Somebody else asked, is this video? I save these videos. I put them on our Instagram feed. I put them in our newsletter. If you're a healthcare provider, get on it. It's at reactiveeducation.com. If you're a patient, get on our newsletter at Reactive PT. I'll send this all out. I'll send links to the articles that I will share as well. Somebody else asked, ocular motor retraining is crucial. Oh, or you stated it, and you are so right. So one of the things that we assess and treat is oculomotor control and the integration of that with our vestibular system and our sensory systems, particularly in the cervical spine. We can see that if there is the way that sensory information is weighted in the brain, or if there is actually an imbalance, it can cause you to turn your head. So you need, because the brain takes in information from the eyes and the ears to tell us where they are, as well as the neck, to tell us where our head is in space. And if some of that information is wrong, it might cause you to turn your head. So you need to assess those pieces and treat those pieces. So absolutely agree with that. Excellent. Somebody else asked about oromandibular dystonia. So we talked about the foot, we talked about the hand, we talked about the cervical spine. Happens in the jaw, happens in the face. And yes, that also is treatable. Laryngeal dystonia, also some of these same components, absolutely applicable in those cases. So I want to share one piece of this, which I love. So let me share one more picture here. Well, actually, let me share two things. Our team often will create these little case studies to share a little bit about what we do and how we do it. This is, I wanted to show you the pie chart in action. This was for a case of a person who had focal hand dystonia. And this was the pie chart that from their assessment and treatment that they developed together, where you can see a large component being motor control, there's sensory pieces, and then there's a little bit of everything else as well. But then they know from a treatment standpoint, heavy on the sensory and motor training. And I'm going to show you an article for that in just one second. This is a person who had focal hand dystonia affecting typing and writing and things like that. And this person did one of our programs. They had physical therapy, they had psychology, they had occupational therapy, and then you can see where functionally they improved. Not just in their everyday activities, but also not avoiding activities, lowering their stress, getting back to life and work where they were using their hands. This is what is possible in dystonia. Now, one of the other things that I hear from a lot of people is there a cure? Or actually, they'll ask me, do you have a cure? And no, I don't have a cure for dystonia. I absolutely wish I did. I'm a physical therapist, and I provide neurorehabilitation with a team approach for dystonia, and people get a lot better and they get back to their lives. And it's not a cure, but it's really, really helpful. And I want to show you lastly, let me say, when people ask me that, I'm not surprised, because one of the things that I also hear from folks with dystonia is they will say their doctor told them there was nothing they could do, or that they would never get better. They'll have this for the rest of their lives. They'll never get better. Or there's only medication and Botox that they can take. Or they were in an online forum and people just kept getting worse, and it was progressing and getting worse. So there's not a lot of, what I hear from folks is not a lot of hope that there is the possibility to improve. And I will tell you, having worked with people for dystonia my whole career, but particularly a lot in the last 12 years, is people can get better. Now, there are many types of dystonia, and some things get better than others. And because dystonia is so variable, there's so many presentations, there's not a huge randomized controlled trial like there is in stroke, maybe, or in Parkinson's, to show what might be effective. But there are some really great small trials in dystonia, and so much we can learn from them. This is my absolute favorite. This is what we've based our program off of, and I'll put the article in the newsletter. It's Nancy Beal and colleagues, and it was a study looking at focal hand dystonia, and they did in person and a lot of home practice of fitness and learning-based sensory, motor, and memory training. So what I love about this is, even from the title, you can see this is not just one thing, it's the whole pie chart. They're going to do sensory training. They were doing motor training. They were helping people with their lifestyle, sleep, how they ate, the fitness level that they did. They had excellent results. They saw people with musicians dystonia and other types of hand dystonia, and those people got back to their instruments. They had great success. It was intensive. They did, and I don't have the exact numbers off the top of my head, but it was like 5+ hours of therapy. It was very intensive, and it wasn't just one thing. It was all of the pieces, because Nancy Beal and colleagues, she's a researcher or was a researcher at University of California, San Francisco. They knew and understood the pathophysiology from the brain standpoint of dystonia, and that one little thing is not enough to change the brain connection issues that have been implicated in dystonia. So very, very small study, not a randomized controlled trial, but very effective and very holistic approach to dystonia. And people get better. People really get better. So I took a course with Nancy Beal when I started my practice 12 years ago. And I was just like, this is what we're going to do. No, I didn't always have a team. PT, OT, psychology, yoga therapy, all of the pieces to get there until the last few years when we started our program. This is why we are doing, and I'll just pull this up here so you can see it, we're doing a free workshop for people with dystonia. It's called Regaining Control in Dystonia. It's online. It's totally free. It's coming up on August 22nd. It's at 5:00. It's for people with dystonia. Now, you can totally send it to your therapist. Therapist, you can come. Why not? But it's geared toward the person with dystonia. And we're going to talk about that neuroscience. We're going to talk about neuroplasticity. We're going to talk about the brain. We're going to talk about our pie chart and the approach, and share with you some practical things and share with you how we do our program. So you know the questions to ask, so that you can find a really good team as well. So that is coming up in just a couple weeks, and I hope you will join us. We are so passionate about dystonia and helping people get the care that they need that can really, really help them. I just realized I'm going to go back because this little question button is new to me. Simone Catherine, I didn't exactly get to your question on splinting. And so let me go back for a moment because I just remembered this, and I'm just going to go back to our pie chart that we had and talk about splinting for a moment. So what a great question. And there's actually a very small study on splinting in dystonia, and it's actually splinting of the hand for musicians' dystonia. It's very interesting what they did. And again, what I'll do is I'll pull up the article reference and I'll put it in our newsletter because I didn't prep it for today to go over splinting. But what they did is really splinted some of the fingers that were having abnormal contractions and allowing them to relax so that they could perform a more relaxed movement. One of the things that I often think of too is that splinting changes the sensory input and can be really helpful. Another thing that I see a lot of is dystonia in combination with hypermobility disorders, and the splinting helps support the joint. So there's so many reasons you might include splinting in dystonia. Let me tell you clinically, not in a study, what I have also seen in splinting. One, I have seen in splinting that it increases some dystonia. But that's really easy to test out. You just test it. Does that increase the dystonic contraction? I use surface EMG a lot. So if I know a particular muscle is overactive, I'll put surface EMG on it. We can try the splinting. We'll look to see if that splint actually increases the dystonia. Sometimes if a dystonia is really strong, the sensory input from the splint will drive more dystonic contraction. So don't do it. So you would watch, you might use surface EMG and you might not splint. And actually for a very long time, because I saw that so often that it made it worse, that I didn't use splinting. But I'll tell you what, I had a person with genetic dystonia in the foot who had to spend so much attention and awareness, and people with dystonia will tell you this. Their mind, like if they're trying to hide that dystonia, if they're trying to walk normal, they're thinking about it a lot. Of course you would. It was so ingrained. I just was like, you know what? Let's try a splint. I wonder if we use an AFO, because it was plantar flexion and inversion, very common if you have dystonia and walking. If we use an AFO, I'll monitor it. I'll see if it increases the dystonia, but I just wonder if it would let him relax a little bit, not think about it so much, and be able to, when you can change the attentional focus, you can allow the brain a little more space and energy cognitively to do many more things. And this splint, the AFO was so helpful. It really, we were running in the AFO, we were walking in the AFO, and frankly, I was really surprised. It's actually the only person that I've seen that has been helpful. Again, I've tried it many times. But hey, I am always open to be surprised and learn more, and be surprised. I think that's one of the things that I've learned in movement disorders and dystonia is to be open, to be curious, and be surprised by the person in front of me. I'm just going back here. I hear you. Somebody said they're going to come to the workshop. I hate living with this and my insurance is not helping me. I got to tell you, my insurance has never helped me either. And it's so frustrating. We work a lot with people's insurances, and it's definitely a number one headache. Insurances I've never found that they've actually tried to help me or my patients. Somebody else said, totally agree. It could be useful for a short time. So going back to the splinting one more time, Simone Catherine, thank you again for asking it. In the article where they did it with some it was called sensory motor retuning. It was for musicians. They did the splinting. They use it for a very short time to retrain movement. So it was really part of a training program. One of the things, this will be the very last thing. I could talk all night, I know, on this topic, and I appreciate your question so much. One of the things that is so important when it comes to idiopathic dystonia is variability. When somebody has developed a dystonia from repetitive use, musician's dystonia, runner's dystonia, writer's cramp, and so on, what we frequently find is that they find something and it works for a while, and then they find another thing and it works for a while, and so on, because in that person's brain, it accommodates and evolves to the sensory input almost too quickly. And so one of the key hallmarks of our treatment is variability in sensory input. So coming back to the bracing, I might actually, and this is what I did for that person with genetic dystonia, is we came up with 3 or 4 braces to use, and to not use them in the same pattern all of the time, and to change the sensory input with them all of the time. So that would be another piece that would really inform your treatment. I want to thank you so much. I love that you had all of these great questions about dystonia. I hope this was helpful. Please share it if it was helpful. Share it with other folks who might see it and might find it helpful for dystonia. And then join us. Oh, let me share this picture. Join us live. Let me grab the website for it. It's August 22nd, so it's a Tuesday. It's at 5 o'clock Pacific time, but we'll record it as well. If you can't join us live, you can go sign up at reactivept.com/workshops. Again, this is a workshop on dystonia for people with dystonia. Thank you so much for joining me today. Keep sending me questions my way. I love hearing from you, and have a great night.